Good afternoon, everyone. I'm Dr. Avinash, consultant pediatric surgeon, pediatric urologist from Cuddles, Secunderabad. So today we are coming as pediatric surgeons. We are discussing very important topics which are affecting our day-to-day in our day-to-day lives to our children. And one of the most commonest complaint from the parents we come across every day in and out is constipation. So constipation in children is a very important aspect and which is psychologically disturbing to the parents as well as the children. So let us go into it and discuss a little more about what is constipation, what are the types of treatments in constipation, and when to intervene in these children suffering from constipation, and also the psychosocial impact it has in the parents as well as in the children. So if you see what are the aims of this session, so first we have to recognize the clinical features of constipation. So not everything we can label as constipation, and there are certain criterias what is constipation. And second thing is we have to become aware of the red flags. So what are the red flags? That is when to intervene and when to consult a pediatric surgeon or a pediatrician nearby, and what are the available treatments. So we have to understand what is the available treatments for constipation as well. So if you see, we have this is a questions where what do these following children have in common. So for example, a 10-month-old girl with hard pellet stools, a 3-year-old girl with frequent complaints of dysuria and hard stools, a 7-year-old boy with a weekly stool that is large enough to clog a toilet, an 11-year-old boy who with daily loose stools in his underpant. So if you see, all these children have one thing in common. So they present variably, but they have one thing in common, is called as the constipation. So let us dive deeply into it and what are the types of constipation and how do we treat it. So you come to the burden of this constipation is very common issue seen in the pediatric world. Around 3 to 5% of pediatric primary visits are constituted of this problem. If you see, around 25% of the pediatric gastroenterologists they deal with this, and almost all the super specialties they come across this problem, especially the pediatric surgeons. And studies have shown that only 60% of the children are responsive to almost like 1 year therapy. So if you see, not all children do respond for the treatment of constipation. So we can understand it is very disturbing for the children as well as the parents. So in layman terms, if you see what is the normal frequency of stool, so most of them parents do come to us saying that the child is passing only a stool once in 2 days, or sometimes he's passing normal stools but only once in 2 days. So first we have to identify what is constipation. So if you see the normal frequency pattern in infants, it is around 4 per day. It can range up to 7 also, whereas in children up to 2 years it is around 1 to 2 times per day, whereas in adults it is around 3 per week to 3 times a day also. So it has a wide variety of presentation, the stool pattern of stool pattern. So basically these patterns are attained by the age of 4 years. So if you see, till 4 years most of the kids are not toilet trained, though some kids are toilet trained at even 2.5 years of age, but most of the times the normal pattern happens to occur at around 4 years of age. So if you come into the medical definition of constipation, most of the times it is a term used for passage of abnormally delayed or which are abnormally formed stools. So there is pattern of timing as well as the form of the stools. So most of the times the parents come and tell us that the stool pattern is like hard, or there are large stools, or there are infrequent stools. There may be pain while passing the stools. So these are all the patterns which regularly the parents come and tell us. So not always these things can end up a patient having or children having constipation. So there are certain criteria when we tell that we diagnose a child with constipation. So the latest criteria is the Rome 4 criteria, which says that So basically, these criteria are different in different age groups. For example, in infants, it is different because they're not toilet trained, whereas in children above 4 years, it is different because at the time around 4 years, they are mostly toilet trained. So I'm discussing about the commonest age group which falls in the constipation, that is the children who are above 4 years of age. So the Rome 4 criteria says that almost like two or more of the following criteria should be present at least once per week for a minimum of 1 month. Previously, the Rome 3 criteria, it was around 2 months, but now it has been decreased to 1 month. And this is generally seen at the age of around 4 years. At least the child should be 4 years. So, what are the criteria? That is two or fewer defecations per week, then one episode of fecal incontinence per week, because these children are toilet trained, so they are not expected to have fecal incontinence, and history of retentive posturing or excessive volitional stool retention, which we regularly see in children, and history of painful or hard bowel movements, which are told by the kids itself, and presence of large fecal mass in the rectum. This sometimes we can see in our examination, as well as sometimes very some parents also do notice them, and history of large diameter stools that can obstruct the toilet, which is also one of the criteria to be diagnosed as constipation. So two or more of these criteria should be present in a 1 month period, that is in the children they should have attained 4 years of age. So once we come to a conclusion that this child has constipation, then what do these children are doing to get these type of symptoms? So there should be some triggers, like usually an acute episode which precedes over when there is change in the dietary habits, or sometimes they may have a cow milk protein allergies, which is though not very common in India, but nowadays we are seeing much, and it is generally seen in the West. And toddlers who are toilet training. So during the period of toilet training, they do tend to have a trigger point like these, and have poor pattern of stool retention also is seen in these toddlers. And older children, most commonly we see these older children who are having a retentive pattern to the stool, and because they try to avoid passing of stools because of inconvenient timing or uncomfortable place or situations. So for example, in schools they may not like to pass in the common toilets, or with the peer pressures. So older children, very common attentive behavior is one thing which is the most biggest culprit of constipation. So if you see what are the differentials of a constipation, like, or you can say what are the types of constipation. So if you see, most commonest type is the habitual constipation or functional constipation. So almost more than 90% or 95% of the children who come to our practice with constipation and who have uh, been confirmed in the Rome 4 criteria, they are of habitual constipation. So there is no pathology involved in this. So entire anatomy is normal, entire physiology is normal, but though everything is normal, they do develop this constipation, that is habitual constipation. So if you see the non-organic causes, that is when there are no abnormalities from the structural or physiological things, then it is developmental. Sometimes the infant dysplasias, or most of the time cognitive defects like autism nowadays seem more common, or sometimes we have attention deficit disorders. These children tend to have constipation, though there is no organic pathology in the gut, but they do develop these habitual constipations. Whereas situational, like toilet training, poor toilet training, or very imposed toilet training, or strict toilet training, and toilet phobias. Then we have social bathroom avoidance, that is the commonest thing which happens to the kids, and sometimes psychological factors like depression, anxiety, or the children who are having a bad parenthood, and sometimes sexual abuse also can induce a fear and cause this habitual constipations. So if you see constitutional, like colonic inertia or genetic predisposition, though not very common, but they are seen more, the constipation is seen more in the teenagers, like colonic inertias, and because they don't develop the typical rectal sensations as well as the propulsive activities of the colon. So mostly seen in the elderly children. And coming to the diet, which everyone think that the most commonest type, the habitual constipation is through diet, but even though said it is not that easy to, even though children we put on a proper diet and give good amount of liquids, they do tend to have this constipation very persistent. So reduced stool volume or dryness, which is the most biggest culprit. Low fiber in diet, children who are low fiber and who are generally not taking adequate water, like dehydrations and underfeeding or malnutrition, they do tend to develop these habitual constipations. So organic, if you see there is some anatomical abnormalities like the sacral abnormalities or the anal opening abnormalities. This is differently not the most commonest type of constipation, and spinal cord lesions and neuropathic lesions, sometimes metabolic conditions like thyroid disorders, which can cause constipation, and sometimes drugs like anticholinergics, which are commonly prescribed. They do, or antidepressants, which are prescribed in children. They do tend to have a predisposition for this constipation. So if you go into the detail of pathogenesis and mechanism of constipation, so for example, we discussed the causes of propulsive force. So whenever there is stool formed in the colon, when it reaches the colon, it has to move through two ways. One is through gravity and one is through propulsive action of the colon. So once there is decrease in the propulsive action in the colon and impaired rectal sensation, which is commonly seen in the elderly teenagers, then it forms a functional outlet obstruction and causing to constipation. And in little younger children, the behavior, withholding behavior, is one of the most commonest thing, which is most commonest etiology of constipation. So when there are these causes, they tend to form a cycle, that is a vicious cycle called as the constipation cycle. So whenever due to these conditions, the stool, there is accumulation of the stool in the colon or the rectum, and it may incite pain or irritation, or sometimes children may do have a little bit of fissures or perianal excoriations. They tend to have pain or irritation. Then they, in their mind, what happens is they have a fear of passing stool. So once there is retention, then the rectum accommodates. So if you see, like, once there is stool in the rectum and child withholds the stool, and what happens is the rectum even it accommodates more, and it dilates and it accommodates more. So even once it accommodates more, again this forms a hard stool. It gets absorbed, the water gets absorbed, forms a hard stool, and large amount of stools. And then what happens is it is very difficult for the stool to escape out, and causing a sore or a bitter feeling of passing stool. So this continues. So again, the child doesn't want to pass the stools. So unless we intervene somewhere in this cycle, the constipation does not really. So before we treat the child, we generally as clinicians want to evaluate the children. So is it really a functional constipation or whether it is an organic cause? So we have to evaluate these children. And how do we evaluate these children? Mainly by obtaining a thorough history. So if you see, the history is very important. Like, we have to go into the family history, and we have to go into their birth history as well, whether the child has passed stools immediately after birth. Because sometimes what happens is there is certain organic causes like Hirschsprung's disease, where the baby doesn't pass stools immediately after birth. So these are pure surgical conditions where we treat in a different way, and they don't form the major part of the the constipation. But these organic causes we have to rule out, because sometimes they may have a delayed presentations. Some organic pathologies can have delayed presentation, so we should not miss these presentations, because the treatment again is very different. So that is what age of onset of symptoms also very important too, because most of the times what happens is they happen during the uh, toilet training times, and timing Then social history stressors are very important because most of the time psychological causes are, and disputes in the family within the mother, father, and going through a bad family may sometimes cause a lot of stress, and they may end up in having these functional constipations. So complete physical examination is very much important. Like for example, if you have a baby, the baby should be well healthy. There should not be any failure to thrive, because failure to thrive again might lead into a different aspect like any other organic causes. But the child generally should be of a normal weight and height. They should be attaining milestones regularly with this constipation. So, and if at all the child happens to come to the pediatric surgeon, we sometimes do what is called as the rectal examination and per rectal exam, and that is abdominal examinations as per rectal examinations. And abdominal examinations, most of the times, in around 50% of these children, we can feel hard balls of stools, that is the fecal impacted stools. And sometimes we can see in a per rectal examination, the stool will be present, and there will be a lot of impaction of feces in the rectum. So very important to evaluate more thoroughly. That is the first general examination is very important. And if you come to a local examination like the abdomen and rectum, we find these things. And coming to other evaluations like the metabolic evaluations, like for example, we have any other history of thyroid diseases in the family or any other medications they are taking. So we have to go through all this and come to a conclusion that the child is suffering with a habitual constipation and there are no other trigger factors. So once we have identified what is the problem, that is whether then the cause of constipation, then there are certain modalities how we treat them. So before treating, whether we need any other tests and all, because most of these parents and other clinicians who send refer the children to pediatric surgeons, they tend to expect us to do some kind of tests, like whether the child is everything is normal, going on normal, or it's not an organic cause. So most of the times habitual or constipation, and any constipation per se, is, unless we rule out all the other organic or anatomical causes, most of it is generally a clinical diagnosis. So we have the room for criteria, and if it is the child falls into this criteria, most of the times we can directly label them as habitual constipation. And sometimes we tend to get basic blood tests like hemoglobin as well as uh, and sugars. And if at all we require, sometimes we might end up getting an X-ray, though it is not mandatory, and we generally avoid because of the risk of radiations. And what do we see in these X-rays? we we tend to see there is a lot of fecal impaction and there is a lot of fecal loaded colon. That is the only finding we get in the X-rays. And sometimes, if at all there is any other obstructions, like which are surgical causes, when there is obstruction in the intestines, we may sometimes find it, but most of the time we see that is a fecal loaded colon. And in teenagers or elderly children in around their adulthood, they sometimes we tend to do little bit of advanced tests like manometries, where we have a suspicion that there is colonic inertia or the rectal sensations are not proper, and then we tend to do a rectal manometry and identify whether the child do have these proper reflexes which are going haywire. So these are the things, but otherwise there is no major test to be done. And to diagnose a constipation, most of the times it is clinical diagnosis. So if you see what are the medicines, like we have a lot of pharmacology therapies, and we do have home remedies, but most of the times it is holistic type of treatment what we do. And in this holistic treatment, first line is, see, we have to break the cycle of this constipation cycle, that is the retention behavior. How to prevent the retention behavior, that is a proper toilet training, and you have to identify these triggers. If at all there are any triggers, try to give them rewards, make them you have to take their confidence and try to break that. And if at all the child has some impaction and the cycle has already set in, so what do we do? So we can divide it into two things. One is if the child has any impaction, that is already the child has developed into impaction, so we have to treat for this impaction. So we have to evacuate the entire stools which are there already impacted in the bowel. So most of the times we do have medicines, that is polyethylene glycol is a good compound which has very few side effects, and we started around 1 to 3 1.5 grams per kg per day, and we can go up to 3 grams per kg per day to have a good evacuation, that is of the impaction. And not only after we evacuate or remove the impaction, we have to put these children on a maintenance therapy. So for the impaction, first we try with medical line of management, that is polyethylene glycol, and later we may sometimes may require enemas. So if at all the stools have become too hard and the children, little elderly children, we try to give enemas or we try to give suppositories like glycerin or bisacodyl suppositories. And but generally we try to avoid these because they have little traumatic effect on their kids, because and it's not a very pleasant thing to be done for our children. So most of the time we start with the medical management, and that is with through polyethylene glycol. If at all, sometimes retractable impaction, sometimes we surgeons do try to remove it manually also. So and once we remove the entire impacted stools, then we have to break the cycle of hard stools and the feeling of these hard stools where the child doesn't want to evacuate the hard stool. So what we have to do is make the stools softer. So how do we make them softer? It is through osmotic compounds, like most commonly we prescribe lactulose, which is around 1 to 3 ml per kg per day, and they do have a little bit of side effects like flatulence, abdominal discomfort, but most of the times these children they tolerate them well. And sorbitol and also lactol, these are all the newer compounds, and they do have the similar kind of side effect profile. When milk of magnesia we used previously, though it has not much of a good role, and better to avoid milk of magnesia because we have newer compounds nowadays. And polyethylene glycol is a very good molecule which helps treating both the evacuation, and that is the impaction, as well as on the maintenance therapy. So other less used commonly are mineral oils, like we have liquid paraffin, which is given around 1 to 3 ml per kg per day. There is a little bit of risk of aspiration pneumonias, but they do work. And there are certain stimulants, like stimulants we generally give for little elderly children, and who have little colonic inertias and little loss of rectal stimulation, sensations, like bisacodyl. These suppose we generally give in tablet forms or general suppositories, and senna is most commonest used. And but generally stimulants are avoided most of the times because we have to train the kids with giving them stool softeners and a good proper toilet training. So after the evacuation, maintenance therapy generally is not sufficient to give only for a week or 2 weeks, but generally we tend to give for a longer period, like around 2 to 3 months. Some children even for a prolonged treatment, they require treatment up to 1 year also. So, and some children, in some small subset of children, they do try to relapse again with constipation, or they sometimes tend to uh, again go in for these constipation recurrently. So most of the times what we do is we generally try to add any other new drug in the same compound or a different type of drug, and again try to treat them. So most of the times recurrences can be prevented with a prolonged course of treatment. So this is what I've told. There's the disinfection. Medically, we can do it with drugs or enemas, and then maintenance therapy with these drugs. And apart from these, though we say diet, liquids, and all these, there's some patients may not get improved. It's easily said than done, but we have to add lot of fiber in the food, and it do help in some certain subset of children. So how much fiber we have to give? So there is a recommendation that the fiber amount of fiber to be taken is age plus around 5 grams extra. So if a child is around 5 years, we have to give a age that is sorry, if a child is around 5 years, we have to give around 15 grams of fiber. So age plus 10, that is the formula we use. And the fiber and as well as the water intake. So most of the children, they tend to have a less intake because they're not much concentrating on intake of water because of playful activities and also because a lot of stress in the schools. So we have to make sure that the children are having adequate amount of water. So adequate amount of water, fiber will do help them in most of the patients, and generally, and we can come down on the pharmacology therapy with increasing in the fiber and water. And if you see there is a different chapter by itself, like what are the fiber rich foods and what are the other types of bulk forming products. So if you see like vegetables, chia seeds, flax seeds, they help in the fiber content. They also absorb a lot of water and forming the bulk of stools. So some people who are not benefiting with these, they can and they have no other issues like rectal sensations and all. Sometimes behavioral therapies can help in them, like giving them good regular toilet training sessions and a reward system. Like if at all we can say them that you go for these tools and you can get some rewards, and we should reward them also with them. And psychological referral generally we tend to give because in certain subset of children who are in the depression and who are having cognitive defects, so they some psychotherapy can be helpful. And as importantly as laxatives are the ones which we generally give on a maintenance for a longer period. So what is refractory constipation? So refractory constipation is one where of all the modalities what we have, and the children are not getting improved with these pharmacological therapies, the psychological therapies, and as well as the behavioral therapies. So we label into a refractory constipation. Generally, we see most of the teenagers like going into they tend to develop this refractory constipation. And before we label them as refractory constipation, again we have to go through a proper evaluation. We are not missing any other organic issues, and we have to reconfirm our diagnosis, and try with a prolonged course of medical management, that is through pharmacological therapies as well as a combination of pharmacological, dietary as well as the behavioral therapies. And if not working, the last option can be surgical options, like if you give perianal botox treatments. And there is one procedure, ultimate procedure for people who are not having this persistent refractory constipation, that is ACE procedure, that is antegrade colonic enemas, where we put the appendix and outside into the umbilical button and try to give enemas antegrade. So most of the times it evacuates and the children are dry by a day. So these are not very common. We generally tend to have it as a last resort. Most of the times it happens only in organic causes and not in a habitual constipations. And fecal incontinence or encopresis is one most important clinical aspect because it is more depressing for the children as well as the parents, because the stool incontinence happening to a toilet trained child should not happen. And if there is stool incontinence, so that is why this Rome 4 criteria has included, Rome criteria has included this encopresis very strictly into the criteria of constipation. And what happens is the stool which is in the rectum. As the rectal volume increases, the rectal pressure also increases, and what happens is then there is the incontinence because of overflow incontinence. So it is a typical overflow incontinence which happens, and it is not due to the lack of sphincter issues. So there are no sphincter issues. That is, the child, when you do a rectal examination, the child, there will be a lot of stool impacted. So these children, what happens is there is overflow of these stools, forming a stool incontinence. So most of the times the parents are worried why the child is having this incontinence. They think that there is something issue going on with the other the continence mechanism, but most of the times it is, when you do a per rectal examination, there is a lot of stool in it. So if you see, coming to take home messages, constipation, a very common problem in children. So each child, it is different presentation, because sometimes it may be hard stool, sometimes it may be the that is the form of the stools can be different. Sometimes the number of stools per week can be different. Sometimes there will be pain, sometimes the other issues, and also constipation can present in a wide variety. But we have to diagnose the actual cause of constipation. There are two. One is the organic cause, when there is anatomical or physiological abnormalities, and when there is no anatomical or physiological abnormalities, that is labeled as idiopathic or functional constipation. 90 to 95% of them, they end up in functional constipation. And before we treat the child, we have to thoroughly evaluate the child. We have to know the mental status. We have to know the how the child is growing, whether there is failure to thrive, and all the other things. And once there is the diagnosis of accurate diagnosis of functional constipation, then we try to treat in these two things. One is the impaction of the stool. We have to treat it with most of the times a polyethylene glycol, very good medicine, which helps in removing the impaction, or sometimes we have to use the enemas as well as the suppositories. And after this primary phase, we have to start maintenance therapy. It has to go on for a long period, maybe around 3 months. And then sometimes most of the children, they end up getting treated in a long course of pharmacological therapy. Children who tend to have refractory, that is, even though we, with all the modalities, they may have refractory, then they need to go in for some surgical type of surgical management, though rare. And dietary factors are very important. We have to have good fiber intake as well as the water intake, and to prevent constipation, because they give a good bulk, and this bulk will help in the propulsive action of the stools. So thank you for your patience, patient listening, and any questions, I'll be happy to answer. Most of the times, the parents and the clinicians who refer to a pediatric surgeon are after a pharmacological therapy given for more than 1 month. So what happens is the parents get vexed, as well as the clinician, the pediatrician, they get vexed, and they think that there is some organic cause which is causing this problem. So most of the times I do get these children. At least I see around 2 to 3 children per day in my practice with this habitual constipation. So the most important thing I give is a reassurance. So reassurance is one key factor for both the kid as well as the parents, and we try to give a longer period of course of stool softeners. And if there is impaction, I try to evacuate the impaction. And investigations we generally don't do for habitual constipation, but if required, we can get an X-ray, and and uh, and we can treat them. And organic causes, yes, we try to identify after a thorough physical examination. We see the anal opening, we see other aspects, and see the sacrum, we see the spine. So if there is no other organic cause, then we can properly, thoroughly, we can give an assurance, and we can treat these children with constipation.